Okay, good evening, everybody. Thank you for joining us. We have these research webinars each month, and just to cover off some housekeeping before we start, the session is being recorded, but it's only the speakers and myself that will be visible on screen. There's an opportunity to ask questions in the Q&A box. We'll answer the questions at the end of the session. If you're happy for us to quote your name, then you can put that on the message. Otherwise, I'll just assume that the questions are anonymous. And I'm really excited to be hosting the webinar today, talking to some of the amazing researchers from Leeds Children's Hospital. So some of you may know that thanks to a legacy, we were able to fund a research centre within the Children's Hospital, and the facility is very much in use, and you're going to hear tonight from some of the researchers about some of the great work that they've been doing. And I'm really pleased to be joined by Adam Glaser. Thank you, and good evening, Adam. Nice to see you. Who's going to tell us a bit more about the research facility and our speakers for this evening. Over to you, Adam.
Thanks, Esther, and good afternoon, everyone. I recognise quite a few of the names on the call, so it's lovely to see you all again virtually. I'm going to try and share my screen now as I just give a little introduction before you hear from my colleagues whose names are appearing on your screen currently. So, that's working well, isn't it? Let's try again. Not brilliant. Andy, have you got my screen, my slides? Can you try on yours? Oh, there are. Can you see a slide now of mine?
Yes.
Great. Excellent. Good. Oh, Children's Hospital Research, marvellous. So most of you will know that Leeds Children's Hospital is a huge hospital in Yorkshire. We're large and busy. We see over 90,000 children in outpatient visits each year. We have over 13,000 admissions to the Children's Hospital and over 13,000 day case attendees to the hospital each year. As well as that, we've got the biggest neonatal unit looking after premature babies in the UK. But big isn't always best. But we know we're delivering pretty comprehensive and high quality care. We have over 30 paediatric specialties represented across the hospital, and we have really good outcomes. So I'm going to tell you a bit about cancer outcomes in a minute or two, but also we know, for instance, that we're delivering the best congenital cardiac surgical care in the UK at the moment. These are figures that are produced by NHS England and the Department of Health, and our outcomes are nationally leading at the moment, which is great. To do that, we've got a very specialised and large workforce. We have over 270 doctors and dentists and 820 specialist children's nurses within the hospital. And buried in that, we have a dedicated research infrastructure. We have 24 research nurses, data managers and research assistants. We can hear from Asyah, one of our research nurses, through the next hour. And we have this lovely children's age-appropriate dedicated clinical research facility that Esther alluded to in her introduction, which was funded by a legacy endowment, the Jeremy Neil Allen legacy, which is administered by Leeds Hospitals Charity. So we had a £250,000 donation, which allowed us to build this fantastic age-appropriate unit to allow children and their parents, when they're taking part in research, to be looked after in a very specific, dedicated area within the Children's Hospital. As well as that, the trust the charity fund a clinical research fellow who is also really driving up our ability to recruit to clinical trials and deliver really optimal research to children within Leeds Children's Hospital. So can you see a slide saying strategies and masters? Yes, good. So what have we done? Well, I've said to you, we've got an age-appropriate children's research facility, but that's okay. Estates are good, but what we've got to actually do is staff them and actually deliver the trials. And at the moment, we run approximately 100 clinical studies specifically for children at any one time. We reached a milestone in 2017 when we, for the first time, recruited over 1,000 children in a year in a given 12-month period to research studies. And we've managed to not only sustain that, but continue to increase the number of kids in clinical trials. At the same time, to deliver these clinical trials, we managed to treble our research income from to breach the £1 million mark. And again, that's been sustained over the last few years. And that's really good news for us. So we've got a big research portfolio, and we're delivering good research to a large number of children. But actually, it's not good enough. The reality is we need to be the best in the north of England, if not I don't think we can ever really compete with Great Ormond Street and the Institute of Child Health, because we don't have their money. That they get £88 million per annum in charity donation for research per annum, and I think that's a bit too aspirational for us. But we should be as good as Alderhay, as an example. We're roughly the same size children's hospital as Alderhay, the children's hospital in Liverpool, and they recruit 7,000 patients to clinical trials per annum. But they also receive £3.5 million per year of charity research money from the Alderhay Children's Charity. So we're improving, and we're getting there, and we've got real potential. And what we're going to hopefully show you is some of the fantastic potential that's available to us in and around Leeds. So I'm going to try and move on. So this is a picture from when the the Countess of Wessex opened our clinical research facility a couple of years ago. And I'm just putting that there, not so you can see me in a nice pink shirt, but you actually see some of the patients who are benefiting from taking part in the research. And I wanted to kind of step back and kind of think, why are we talking research? Why is this important? And I think it's really hard to imagine how tough it is to have a kid who has a life-threatening illness. And when most of us start our families or think about planning having a family, none of us imagine in our most extreme kind of worst nightmare that our children are going to be ill. The vision is we're going to have a successful pregnancy, we're going to have a healthy baby born, and actually those kids are going to go to school and develop and be healthy all the way through. But for a small number of families, that dream is derailed, and their kids suffer from some horrendous disease. We can see in this picture that the young man on our right who has Duchenne muscular dystrophy. And Asyah is going to talk a little bit more about this, but this is a condition that is life-limiting. So these are children who are born completely normal. Externally, they look fantastic, and they develop normally as babies. And then progressively, these young men or boys lose their motor skills through their first and second decade, and end up sadly dying. But no parent ever imagines that's going to happen to them. And it's reasons like this and stories like this that actually make me and others who you're going to hear from want to go into research, because actually, whilst we do have good outcomes in Leeds and across the UK and the developed world, but for most childhood illnesses, we sadly don't get everyone better. And sadly, there are families who are faced with the loss of a child, and hearing those parents crying and watching the parents and listening to these terrible tragedies is absolutely heartbreaking. And until we can actually rectify all this, we have to move heaven and earth to improve outcomes and get better treatments. And we will do that through investing in research. So to give you an example of this, I'm a paediatric oncologist. I deal with children with cancer. So this is a slide which comes from Cancer Research UK. And what you're seeing along the horizontal x-axis, it says years since diagnosis from cancer. And on the y-axis, the vertical axis, it's showing the percentage of children who survive. And going from the bottom, the green line upwards, what you're seeing is stepwise improvements in outcomes. And the top line shown there are children who are diagnosed between, I've got up here on my screen, up until the year 2000. and from 1996 to 2000. And what you can see is you've got about a 75% survival rate showing on that slide. Now, that's really great. That means that 75 out of 100 kids are going to get better. Whereas in 1966, roughly the time that I was born, only 25% of the kids would get better. So we have made fantastic improvements, and it's those stepwise improvements that have come, but that make us want to do more and more research, because the improvements actually come from us taking part in national and international clinical trials and research all the way from developing new drugs and trying to understand the pathology and the molecular changes that cause cancer, but also new drugs and new treatments to help us to improve the absolute survival of kids with cancer. And if we move on slides, what I'm going to show you is some data that's fresh off the press in 2021, that in Yorkshire, so the Children's Cancer Centres in Leeds and Sheffield, we have survival now, which has improved to 86%. So for children diagnosed up to 2016, we know that 86 out of every 100 kids will now survive. So even better than the 75% that Cancer Research UK put out on that slide up for children diagnosed up to the year 2000. So we're improving and improving. I can share with you that this data from Yorkshire is ranks absolutely in the top division internationally. We're alongside parts of Australia and Canada who publish the most successful rates internationally. So we should be very proud of these achievements, which result from a really systematic use of clinical trials. What that actually means, my slide changes. What that actually means is we're saving more people's lives. So the figures I've shown were for kids diagnosed up to the age of their 15th birthday, but we've shown similar improvements for young adults, for teenagers and young adults. And what this slide is showing, the pink bars are showing the number of children and young adults up to the age of 29 who would have survived if we had survival figures from 1990. And what the yellow bars are showing are the increased number of lives we're saving each year. And so the improvements have led to 600 additional young people surviving and becoming long-term survivors and living adult lives as a result of the increases in survival that we've obtained in Yorkshire as a result of the clinical research that we're doing. So this is why I do research, because I want to stop having to listen to the tears of bereaved and grieving families. That I'm confident we will achieve this goal, potentially not in my working lifetime, but I think over the next 50 years we will get to the point that we can cure almost all children with cancer. So that's my kind of bit about children's cancer, but there's much more than children's cancer research going on in Leeds, and we have a whole comprehensive research network portfolio. We have a clear vision for our research delivery, and that is to ensure that research is core business in the delivery of optimal clinical outcomes in the care of children, young people and their families at Leeds Children's Hospital. We know this is essential. We know from that there's very strong evidence that research active clinical units deliver much better and improved clinical outcomes, even for the children or patients who are not involved in research directly. The fact that you are being looked after in a research active unit directly enhances the outcomes delivered by the clinical teams. So research is really important if we want to obtain this goal of giving the best possible care and the best possible outcomes for every child we treat. And we're going to do that through providing an optimal environment to deliver applied health research. We're going to support service users to access research so that research becomes an always event, not a never event. Every child and family looked after in the Children's Hospital should be offered access to a research study or more than one research study. But to do that, we've also got to create and sustain a staff base who are able to deliver this research. And that also comes with its own challenges. So I'm going to stop by saying that I think the future is actually bright. So whilst I've tried to put on the heartstrings a little bit by talking about dying children and bereaved parents, actually, we're in a position that we're doing well. The future is good. And I think we're now in 2021 at a point where we've got a really good platform that should act as a springboard to us becoming a absolutely internationally leading research centre for children and young people who are sadly experiencing ill health. We have a fantastic local health economy. Leeds Teaching Hospitals, in partnership with the University of Leeds and Leeds Hospitals Charity, have a unique opportunity to work together here to allow us to provide world-leading research in quite a significant number of clinical areas across the Children's Hospital. I've talked a bit about cancer, and one of my colleagues, Bob Phillips, is going to talk about some fantastic work that he's been doing as well. I think cardiovascular, we're a huge congenital heart disease heart unit, and we have real strength that we can capitalize on. The adult, in the university, there's a very major adult cardiac research program. I think we can benefit from that to capitalize upon the clinical position of strength to really develop our cardiovascular research. Evie Robson is going to talk a little bit about cystic fibrosis. Leeds is internationally known for a delivery of clinical trials in cystic fibrosis and has been ever since I was a very junior doctor and a medical student. People used to talk about the pioneering work in Leeds, and we need to make sure that continues. Diabetes mellitus, we're absolutely at the forefront of work with the artificial pancreas. We've just been awarded earlier this week part of an £800 million programme grant to support young people with diabetes with a brand new web designed app for them. We're also doing fantastic work on neuromuscular, and Asyah is going to talk about some of those diseases. Another real strength in Leeds is our outcomes research. I've tried to show you data about children's cancer survival. Well, now to actually mine that data takes quite a lot of expertise, but we have it. We have the best children's epidemiology unit in the north of England, and probably it is apart from our colleagues at the Institute of Child Health at Great Ormond Street, we are the biggest and best unit at outcomes research, and we need to capitalise upon that to really show how good we are in delivering children's care in Leeds. The other reason the future's bright, we're going to have an even bigger children's research facility in Leeds. So in the new Children's Hospital, we're going to move from a 6-bedded unit to an 8-bedded unit. That's great. We're about to build a new bio-suite, which will allow us to deliver state-of-the-art advanced cellular therapies, which is the real cutting-edge molecular and genetic therapies and gene therapies. So things are looking really good here, but we need investment. We cannot do this without support, financial support, and I hope that we can work, have this ongoing dialogue and relationship with the charity to provide this. And with that, I'm going to stop, and if that's okay, and hand over to Asyah. Oh, I don't want that slide, thank you. So I'm going to hand over to Asyah, one of our fantastic paediatric research nurses. So thank you very much. Asyah, over to you.
Thank you, Adam. So I'm going to talk a little bit about my role and what I do as a neuromuscular research nurse, and a little bit about the things that we do outside of seeing patients, so development, those kind of things. So where it all began, before 2015, the research teams were separate. So we had paediatric oncology research team and a paediatric research team which covered multiple specialities, and they were part of the Medicines for Children research network. But since 2015, we've been working together. We joined as one big team, and we're now known as the Leeds Children's Clinical Research Team, located on D floor in Martin Wing. So these are my lovely nurse colleagues. There are 18 nurses. We have 3 senior research nurses, and we have 7 admin staff that support us with our research as well. So our main aim is to ensure that the research that we deliver, we promote it within the trust, and we continue to provide the support to clinicians and patients that take part in our trials. Some of the specialities that we cover, I think Adam covered a few of these as well: respiratory, oncology, hematology, neonates, hepatology, renal, neurology, and then neuromuscular under that as well. And those are a few. I've probably missed quite a few more. Next slide, please. So this is me. Hello. So I have a background in children's neurosciences, and in 2017 an opportunity came up for a secondment. So I took that up because I've always been really passionate about research, and I haven't looked back. I stayed and continue doing things, because I just love research. And because of my background in neuro, most of my trials are neuromuscular, some epilepsy trials as well. But my role as a neuromuscular research nurse involves lots of different things that you might not think a nurse typically does, which was, some of it was a surprise to me. So some of those things are coordinating trials, so, liaising with clinicians, other AHPs, industry, and setting up trials in the trust. So when we get a new trial, we approach different departments to see that, to make sure that we've got capacity to deliver these trials. Caring for patients that we recruit. So we're usually the first point of contact for patients that are on trials, if they're not well or appointment related, anything like that, we will get called. I'm also responsible for all aspects of the data. So we collect data, obviously, lots of it, entering data, and then liaising with sponsors. And then when a trial finally comes to an end, sometimes that can be a year, sometimes that goes on for many, many years. So depending on how long it's been going on, there can be lots of data when you close a trial, so it can take quite a bit of time. And then last year, I applied for the Florence Nightingale Foundation leadership program. So we're always encouraged to develop ourselves, enroll on courses all the time, because the trust is quite dedicated to developing staff. I was successful, and it's something that I am proud of, because it's a very competitive national program aimed to develop nurses and prepare them to be the future leaders of nursing. As part of that program, we had to come up with an idea for a quality improvement project, and I chose to look at the uptake of research in the Black and ethnic minority patients, because from practice in research, we know that it's not as great as it could be, and there are lots of barriers to that as well. So it's an ongoing project. I'm looking at how we can improve that, and working with the Duchenne Muscular Dystrophy Hub as well. So I can talk a little bit about that later on. And then the DMD Hub, which I've mentioned. So this is Jack, one of our lovely DMD patients, with my colleague Martin. So Duchenne muscular dystrophy is a neuromuscular condition, and it's a rare fatal genetic condition that, obviously, I think Adam has mentioned that it's eventual death in, their 20s, 30s, and that is improving with research. But obviously there's a lot more we can do. So it's a disease that almost always affects boys, and they tend to be diagnosed before the age of 5. So the next slide shows some of the DMD trials that we've taken part in that have either recently just closed or are ongoing. And Vision DMD is a trial that was quite exciting. It's a steroid alternative with fewer side effects. It was quite an onerous trial. There were lots of investigations, procedures, lots and lots of visits to the hospital. So it took a lot of dedication from families to take part in these, and we recruited 5 boys to this trial who successfully completed it. And 4 out of those 5 boys went on to compassionate use of the drug at the end of the trial as well. Next slide. So Adam's done a really good job of talking about the CRF, so I'll keep it brief. It opened up in 2018, and it was made possible with the generosity of a very large donation with Leeds Hospitals Charity. It's a dedicated facility for us in clinical trials with 6 beds, and what this meant for us was we could increase our trial capacity, especially within neuromuscular, because we were quite limited to the trials we could take part in and the number of patients we could recruit. Prior to the CRF, the trial visits took place on the children's day unit or in outpatients, and we were limited to the days that we could have those visits. So the opening of the CRF has massively increased our capacity, and you know, just the dedicated space for children means a lot. So the next slide, it's just a short video. Caitlin is one of our cystic fibrosis patients, and I'm just showing you this so that just to give you a patient view on what it means for a patient to have a dedicated facility.
I was diagnosed with cystic fibrosis when I was 3 years old. I got involved in the trial when my doctor suggested that it would be beneficial for me to be involved in, that it might help improve my lung function a bit.
Can you tell me about what it's been like involved in a clinical trial?
I've been excited because I feel like I'm getting better, and I think it will help other people get better as well. When I come in for my tests, I have basics like lung function test and weight, height. You get cough swabs to see if any new infections have grown, or wee samples, or blood pressure. Most people see I have about 40 tablets a day, at least. So it's just pretty much another tablet, just adds to all the rest of them.
We're currently now in your children's clinical research facility. What do you think about it?
I think it's nice, and I think there's more space for the whole research to kind of be done.
And it'll hopefully allow us to probably do a bit more clinical research and take longer visits with children and undertake more clinical studies, expand and be able to take 24-hour studies in cystic fibrosis, in neonates, diabetes, oncology. So that's what we're aiming for.
So how is the research in children done differently from research in adults?
Some of the studies that you've been involved in already have already been undertaken in adults, but the study drug works differently on children, and we need to work out how that works. What we also want to do is look at the long-term safety of the drug and then use that data to compare that with the adult data.
I just feel like it's a way of me giving back to all the people that have helped me in the past. Without all those people helping me out, I feel like I wouldn't be where I am today.
As I mentioned earlier, the DMD Hub UK, one of their main aims to increase trial access for patients, both children and adults. And I mentioned about a National Neuromuscular Research Nurse Group. So this was an idea that I came up with after meeting other research nurses from different centres and taking inspiration from my oncology research nurse colleagues who have something similar set up. I felt that we could do this in neuromuscular as well. So we set up a group with the help of the DMD Hub, and the first meeting took place in February 2020, so just as the pandemic started, and we haven't been able to meet face to face, but we've managed to meet quite a few times virtually. The main aim of this group is for equitable access for all DMD patients across the UK, and not just patients that are within our own caseload here at Leeds. And I know this happens in other specialities, but I think this was one area in neuromuscular, it was quite a challenge. So what we've started doing is sharing, you know, patient information, obviously with their permission, when we think someone's eligible, but we don't either have the capacity or the trial taking place here. And successfully, we've recruited about 5 boys from different centres across the UK to our trials here in Leeds. And one of the other things that we've managed to achieve in the last year is CBT training with the help of the Duchenne Hub, because we find that when families and children get to the end of a trial, it's quite an emotional time, because a lot of these Duchenne patients are at the point where they're losing their ambulation or have lost their ambulation, so they're in a wheelchair. And a lot of the trials, the criteria for taking part in a trial is that they have to be ambulant, be able to walk so many meters. So it can be a really challenging time for families, and it was suggested that we do some CBT training to support families. So we've done that as well. So there's lots of exciting things that are coming up. And, you know, as research nurses, we're always doing things to improve our own knowledge, skills, and the way that we deliver trials and look after our patients. Thank you.
Hello.
Hi, thanks, Bob. I wasn't sure if Adam was going to introduce you, sorry. So very happy to hear next from Dr. Bob Phillips. Over to you.
Thank you, and thank you everyone for still sticking around. My name is Bob Phillips. I'm a paediatric oncologist part-time, so I'm a doctor that also looks after children and young people with cancer, same as Adam. And I'm also a researcher with the other half of my time at the University of York. I'm coming to tell you about something that that Leeds Hospital Charity has funded part of, and tell you a little bit about why we're doing it, what we have from some previous data, and where we hope to go forward. Can I get the next slide, please? Now, it's part of something called the SHARE study, and we set this up just about a year ago now, actually, at the kickoff of the pandemic. Understanding that this turmoil and lockdown and uncertainty would have significant psychological and emotional effects upon the families of children and young people that were going through treatment for cancer. Now, you might ask, why do we call it the SHARE study? And the next slide will tell you. It's one of the dodgiest acronyms in the entire universe. And this is something that you will now learn about researchers. They tend to start their study by thinking of a great idea, and then they try and think of an acronym. They fail, and so they stick with a decent word and then just make their title fit it. And that's where we get the How to Support Children with Cancer and Their Parents During the COVID-19 Outbreak, Understanding Experiences, Information, Support Needs and Decision Making, which is why we call it the SHARE study. Next slide, please. What this has in it is actually 2 main work packages, or 2 main themes that go through it. The first is a series of surveys that were done with parents and young people over the course of the year, and we've got one last one coming up. And the other part is a second work package, or second thing that's being done, which is an online intervention that we aim to improve well-being, reduce anxiety, depression and stress levels. And this was on the basis of something that's already in existence called the Hope for the Community course. Hope for the Community is a community interest company that runs online psychoeducational programs. The bottom there, it says informed by PPI, not payment protection insurance, not proton pump inhibitors for those of you that have had stomach ulcers, but patient and public involvement. So basically, a lot of researchers used to just do research because they were interested in it. I need to know about eyebrows. But no, now we actually start our research by saying, we think this is interesting, and then going out and talking to young people, to parents, to those who are affected by the condition to say, is this interesting, this research? What is it that we should be trying to measure to know if we're getting it right, if we're getting things improved? How would you feel about doing a survey that was 406 questions long, and then we got told very clearly that that wouldn't get filled in, but if you cut it down to 3 questions, then it would get filled in. So it's working with representation from those affected to make sure that your research works properly. Now, what we did was we did it in 2 different ways, and this online Hope in the Community, we can see on the next slide, is a 6-week program. It runs over a number of different themes, and it's based around a sort of cognitive behavioral therapy, CBT approach, but with elements of something called gratitude therapy. And that is really about trying to get people to focus on the good things that exist in life, not just focusing on problems. And through 6 different weeks, there's a series of web pages that you get put through. There's a sort of an online forum, which is sort of a bit like Instagram without pictures, where you can send messages to each other and support each other as you go through this course. And it's up to 50 people could have taken part in one of these courses. If you go on to the next slide, please. We delivered it in 2 ways. The traditional sort of classroom style way of giving the lesson every week and nudging people along with trained facilitators to fill in their hopes, their goals, what they'd learned from the week, to complete it properly. And then we also used a different approach. Next slide, please. Oh no! Is there there, that's the one I was looking for. The Netflix style approach, where we just dumped the entire course on a Monday and said, binge it how you like. Really, really just get through it, move on to the next episode when you've done one. And why did we do this? Because in our PPI and in our considerations, people were saying, well, to drag it out over the 6 weeks, why do we need to do that? Why can't we just get it all up front and move through and ourselves? And so we put out 2 courses in order to compare which one worked and did it make a difference. Next slide, please. Now, on this, the first classroom style course, about 2/3 completed at least 3 of the 6 weeks. You're aiming for around about 60% completion rate on these online courses to say that you're getting reasonable levels of engagement, and 44% completed the whole course. For that, you're aiming for 1/3 to have completed the whole course. So in terms of engagement, this drawn out 6-week one worked really, really well. Did the Netflix style one work better? The next slide shows us it was a complete disaster. Only 1 in 10 completed at least 3, and they were the ones basically that went on to complete the whole course. Netflix dumping this did not work. There was something about taking people through week by week that made a difference. But did it make a difference to how they felt? Yes, we cancelled that idea completely. Did it make a difference to how we felt? These are validated scales. So they're sort of like your take a break questionnaires, your just 17, mostly A's, you should wear skirts. Mostly B's, you should not wear skirts. This is the depression, anxiety and stress scale. Set of questions, what happened? Well, they had a 0.5 score increase in a good way on the stress scale, 1.2 in the anxiety scale, and 0.9 in the sadness or depression scale. Now, what does that mean? Well, if you move by a whole point, by 1.0, then you've made a significant clinical improvement. The way that we're interpreting that is that going through this course made people mostly less sad, mostly less worried, but still stressed because they were smack bang in the middle of a pandemic. Not surprising. The next slide shows you a different one. This is the Webb-Wim scale, the Warwick Edinburgh Wellbeing Mindfulness scale or something. When we started, these are the levels of the proportion of those patients, those families, the parents that were part of this, who had some degree of mild mental health disorder. So this is an anxiety disorder or a depressive disorder. Probable in 1/4 of them, possible in nearly 1/2 of them, and only around 1/4 were unlikely to have a diagnosable disorder when this started. 6 weeks later, this one shows, with the results on the next scale, slide, sorry, that we've gone all the way up to 9 out of 10 of them no longer having a likely diagnosis or diagnosable mild mental health disorder when they were through. This course seemed to make a massive difference. That's slightly cheating, because actually general practitioners will know that the way you often manage people that present with mild mental health disorders is to see them again in around 4 to 6 weeks. Because a good chunk of people over that time period will improve on their own, probably around a quarter. This is 9 out of 10. This is better than that. And it fits with the other evidence about this making a difference. So we ran that once, but we wanted to run it again. And Leeds Hospitals Charities did agree to fund a further extension to the research pilot, because we'd got some improvement. And what the Hope for the Leeds Hospitals Charity version did was to see, can we make it better? The week by week, 6 week classroom one, we had one session with a meet the expert. Ostensibly, I was the expert. And it was an hour chatting in an evening with the people that wanted to come along and ask questions. It was really, really well received. And so we're just finishing up with 5 out of 6 weeks in. We're just finishing up the first one of these where we did that every single week. The feedback so far is that it has made a great difference to those people who've come along. They've really valued the opportunity to expand their understanding, to ask the questions that they may be a little bit too worried to ask their own clinical teams, and felt better. We don't have those scores about depression, sadness, and so on, but we are hitting over 50% of people have already completed at least 3 of the modules, and that's 5 out of the 6 weeks in. We let them go on for a full 8 weeks to complete the rest of the course. If you go on to the next slide, please. That's what we're getting with this sort of talking therapy model of taking people through bit by bit. But what could we do differently? And on the next slide, we will think, is it that the coffee morning type that we've done with it every time, having one a week, talking to the experts is the way forward? Would it be that we should drop in a daytime element to this course? Could we advance it further? Could it be that there is actually more localized stuff with literally a coffee meet once we're allowed to do so again, and drawing the people who want to physically meet each other rather than having it all online and not in real life? Where could research go forward is the next question, because we're never satisfied. It's absolutely brilliant to make an improvement, but it's almost never do you hit the absolute height. And so you need to do further research to take it on. What else could we do? Next slide, please. Could we, most of our patients are extremely thoughtful, as you can see from this picture, could we go one step further forward and expand this to young people? Or could we do programs that were directed for parents in order for them to help their young people directly with the distress and the stress that goes around having a diagnosis? Or could we be really brave? And next slide, please. Could we move to actually doing direct work with teenagers? Nick here was treated by me many years ago, and he sent me this slide when I asked, can I have a picture of you to use to demonstrate what a teenager's like going through cancer? And his hair didn't grow back. Mine fell out at almost the same rate. He's been involved with loads of research that we've been doing in the future. And finally, I managed to publish with him recently. But how can we modify this, which is designed for parents, to actually directly help teenagers work their way through this? More research is needed. I'll move on to the last slide, and I would like to say, by all means, follow me on Twitter, hassle me wherever. Do follow the Hope in the Community people as well. And thank you for putting the money in to do this research and advance this further. We were hearing about research that was millions and millions of pounds to make it move forward, and that is absolutely necessary for some things. This research was only 10 grand. Now, that's not an only for anybody's single pocket, but in terms of research money, it's amazingly good value for money for the improvements that we're seeing here. Thank you very much.
Thanks, Bob. I think I've got to be quicker off the mark. I didn't introduce you quickly enough. So thanks so much. That was, as always, really entertaining and informative. We're going to move over to something slightly different now. It's always quite hard to follow Bob as in terms of talks. there was I went to a Finding Sense of Tumour conference, a conference for young people with teenagers with cancer. And I had the pleasure of talking after a boxer who'd been beaten senseless by another British boxer a long time ago. And he walked or stumbled onto the front of the stage, this lovely boxer, as he was recovering from his brain injury. And he just was very empowering, and he was shouting out at the audience, "You can do it, you can do it, believe it." And it was so hard to follow this guy. And it's a bit like following Bob, actually. It's a very hard act. But actually, I'm delighted to say that Evie is just the person for the job. Evie is a consultant in paediatric respiratory medicine, and another one of our stars in the Children's Hospital, because she combines a really busy clinical practice with a really successful research program. So Evie, over to you. Thank you.
Thank you, Adam. So yeah, my name's Evie Robson, and I'm really pleased to talk a little bit about research that I've done and that I'm involved with that's really benefited from the Leeds Charity funding. So I'm a respiratory paediatrician, so clearly that's where my research interests lie. And I did an MD, which is a bit like a PhD, but less of one. That medics can do, and I did an MD looking at cough monitoring and nasal inflammation or snot, and I might not go into too much more detail about that. And it was for children and adults with a condition called PCD, which is actually primary ciliary dyskinesia. And I had a comparator group of patients with cystic fibrosis or CF. So both conditions cause problems with airway clearance and ultimately damage called bronchiectasis. And it was a lovely little video that I'd not seen before of Neil and Caitlin, actually. So Caitlin's got CF, and CF has previously been a significantly life-limiting condition, much less so now with kind of the amazing clinical trials that have been going on. We're really proud to be one of 4 national PCD centres. So I lead the management team supporting about 160 children with PCD in the north of England. And as Adam alluded to before, we're really proud of our long-established regional cystic fibrosis centre and care for over 230 children within our network, and Leeds is part of clinical trials networks for both cystic fibrosis, and we're just developing one for PCD. PCD is quite a rare disease, and it's many years behind CF in what we're managing to do. Next slide, please, Andrew. So, as most of you know, funding for research is often really complex, and I think what I wanted to show is my study, I think, depicts that. Like lots of PhDs and MDs and postdoctoral things that everybody tries to do, it's really tricky to get enough money in a pot to cover all aspects of your time. So I just wanted to briefly mention, I had my tuition fees covered by my primary supervisor, who's based at Great Ormond Street Institute of Child Health, where my degree was registered. I managed to wangle a clinical fellow post in the adult cystic fibrosis unit in Jimmy's, which was amazing. I think I was at the right place, right time. But that allowed me to have access to the University of Leeds as well, and had an honorary contract. So that was really useful to kind of have somewhere to be, gain access to kind of books, kind of library and things like that as well. A year into my research, I finally was awarded a CF Trust grant, which was fantastic because that pretty much paid for my research wage and a small amount of consumables as well. I felt really lucky to also have access to financial support from the Leeds Charity for all my travel. Now, this might sound quite trivial as an expense, but it really adds up. So my base university was at Great Ormond Street, and so was my primary supervisor. So there were at least 2 trips per month for the whole 3 years down to London on the train, and probably 2 or 3 flights to international conferences that you have to do. And on a kind of going back from to almost a student wage with 2 kids and a bigger mortgage, that's you know, it's pretty tough. The Leeds Charity also funded a specific test for processing, that's meant to be a snot, processing my nasal inflammation samples, and that was, gosh, £7,000 or £8,000, which is, like Bob said, it's quite an immense amount, really. I know it's not immense in the grand scheme of things, but it's massive, and it allowed me to do that part of the project because it couldn't have been funded by the CF Trust, that little part of it. The speed of the financial and logistical support I felt was also really, really important, and absolutely much appreciated. Following on from that, we've been really lucky, and Adam's mentioned it as well, to host the first Children's Hospital Charity research fellow this year. And this is an immensely valuable step into research for budding academics, clinical academics. It gives them experience in running the clinical research facility trials, and the ability to use a year to work towards a post kind of doctoral degree, which actually, looking back, I could have really done with. I feel like actually potentially my first year was a bit faffy because I wasn't quite ready to kind of go for funding and things. Next slide, please, Andy. Finally, I think I just wanted to say that similarly, as Adam and Bob have both said, one of our Leeds goals is to be a centre of excellence for research and innovation. Even more so with the driver of an excellent new hospital, new equipment, and there's significant evidence that research active hospitals have better patient outcomes. From my own personal perspective of my project, I think in the words of Tesco, every little really massively helps. So you might not think it's big amounts, but actually some projects wouldn't be possible if it wasn't for kind of charity donations and the ability to give kind of small, large amounts, whatever. I think it's really important that as a team, we've got real interest in charity events in our charity, and we get muddy for the cause, but we truly appreciate the support that we rely on to drive research forward for our patients. This is our CF children's and adult team doing Total Warrior before we all had to wear masks and lockdown. But thanks very much for listening.
Thanks, Evie. So I think for the last 5 minutes was meant to be Esther and me listening or answering questions or having a discussion. So Esther, do you want to chair this bit, or would we just open it up to?
Yeah, certainly. I mean, hopefully we'll get some questions come through in the Q&A. I hope that people have found it interesting. I certainly have. And I think one of the things you've hopefully seen is how much we work in collaboration. So you've probably noticed as we went through all the slides, a number of other charities names coming up, and that's because it's not just about one charity playing a part in this. We work collaboratively, which means when people donate money to Leeds Hospitals Charity, we're able to make it go further and have a greater impact because we do work closely with other charities. And I think the other thing, hopefully, that's a lot of people will have seen from this is how amazing the teams are here in Leeds. I mean, you know, the people that you've heard from this evening are absolutely phenomenal, and there are lots of other people as well in Leeds Children's Hospitals that are great at research. And whenever I talk to Adam, I always think we need to raise more money, because I just hear the passion in his voice, which hopefully you've all heard this evening, and from the other people that have been presenting, because people really want to make a difference. And we can see from some of the work that's already been achieved, huge step forwards have been taken because of the funding that's gone into research. And the thing that stops us from further developments and finding more cures and making life better for more children is a lack of money. And we know that more money going into Leeds Children's Hospitals to fund research will have a significant impact on the children in Leeds and the wider region. And I'd be really hoping now to see some questions pop up in the chat. There aren't any at the moment, but I know that there were some questions from some of my team asking, so particularly very interested in what Bob was talking about and how that could be relevant to other patients. I don't know whether you could answer that, Bob, like, you know, because anybody would benefit
Yeah,
from
in
that.
other patient groups. So the online Hope for the Community gang have one for parents with children with autism and autistic spectrum disorders, and they've got a generic carers course. But the team are extremely welcoming and will work with groups to modify their base course that they've got to develop it and push it further forwards. It's always a balance between taking a sort of a very specialised approach, and to some extent you think cancer's specialised, but actually there's so many different variations of experience within cancer. It's already relatively broad, and if you were then to roll it out to all neuromuscular conditions, that might be tricky. But it might be that a course for parents of boys with muscular dystrophies would be one that could be on the cards, or parents of kids with CF could be one that's on the cards very straightforwardly. And they're willing to develop those courses. Now, to do that, we'll need decent engagement from the patients. It will need clinician input as well. It will take weeks and weeks to come up with something that's a sort of a testable modification. And then it'll probably have to run 2 times before you know whether it actually works or not. So these aren't things, but they can be done. And then you can roll them out, you can trial them, you can test them, and you can make them available for a broader group of people.
That's brilliant. Thank you for that insight, Bob. Really interesting. I was also really interested when Asyah was talking about the you know, the take-up rate of children from Black and minority ethnic groups, and just, you know, I don't know if you could just expand a little bit about you know, health inequalities and how, you know, research can really help to, you know, progress that and really help people who maybe need, you know, to sort of access the clinical trials and things that we could be doing differently, maybe.
Yeah, so within neuromuscular, Duchenne muscular dystrophy, we know that we have patients from, you know, Black and ethnic minority families, but from practice, I know that only one family, one patient has taken part in the trials that we've had over the last few years. And there are lots of barriers. It's not just that, you know, people from Black and ethnic minority backgrounds just don't want anything to do with research. It's not that. There are lots of barriers to it. So it's unpicking those barriers, and I think, again, that takes a lot of time and work, and working with families as well. So that's something I'm really interested in doing, is engaging with families to see what we can do better to improve uptake of research, how we can make it more accessible, how we can help them. One of the examples I have is that when we have research trials, when we have patient information leaflets, that you know, trials that are international, quite often a lot of the languages that these families speak and can read are not available. And, you know, you'll go back to sponsors and say this as well, but it's difficult. So there's a lot of work to be done there. And not just neuromuscular, I think lots of specialties. And I think I had this discussion with Adam sometime last year when I started on this program as well, because is it that in oncology it's the same, Adam? Do you find that?
Yeah, no, I think it's a real issue. It's not just oncology, it's everywhere. So I've just completed a big prostate cancer program of research across the UK, and Black men are about 4 times more likely to get prostate cancer than white men. And yet we could not get Black men to engage in a research program that was successful across the UK. We had really high participation rates, but we couldn't. It was very, very hard to get the Black community to engage. And even though they know there's a very high problem with this particular condition that we were looking into. So it is a real problem, but that, so it's partly engagement, but I think the work that you're doing, Asyah, will really be helpful to try and understand what the barriers are, and because once we know what the barriers are, we can start to address them and help people to overcome those. But I think it's something we mustn't give up on. So I was tempted to put up a slide actually at the beginning in my talk about some disparities in survival between ethnic groups that we've identified for young people with cancer across Yorkshire. And so we know there are certain cancers such as lymphoma in young people where the Asian community have much worse outcomes than the white British communities, and we don't know why. And we just really do not understand why there are these disparities. So there are real health inequalities, and we really have to grab this opportunity to explore why people are not taking part in research and why there are outcome differences. And I don't know what, I really haven't a clue what it is, but we've got to start looking at it. You know, we're working with Becky Baldero-Booth and the charity, Leeds Hospitals Charity, to develop a research program that's going to look at leukemia outcomes for young people, but in parallel with outcomes for people with beta thalassemia and sickle cell disease, which are both blood disorders which almost exclusively affect Black and Asian communities. And we want to look to see if the outcomes of quite similar interventions for leukemia and thalassemia and sickle cell disease, such as bone marrow transplants, to see if there are different long-term outcomes which might be attributable to ethnic or racial features. So I think we've got to do this kind of work. I think Leeds Hospitals Charities and other charities are working out and realizing that there is a real problem with access to health and health outcomes from different ethnic groups, and I think but I don't know why at the moment. So Asyah, your work's amazing, and we will find out, I hope.
Hopefully it's a big project, because obviously there's just so much to it, and it will take time, but yeah, we'll hopefully get there.
Yeah, and it's obviously very worthwhile doing, because, you know, if we can get it right for children, then it is meaning then a better future for the city, isn't it? Which is amazing.
Yeah, and I think that's right, Esther, because if you don't get it right at the beginning, and you know, one of the other areas that you and I have spoken about is things such as food poverty and deprivation. So we know that in across the UK, about 20% of children were living in food poverty before COVID-19. We know that's got worse during the pandemic, and given the really multicultural nature of Leeds and the huge and the ethnic diversity amongst the population of Leeds, I think we may be at real risk for our local economy of seeing huge amounts of food poverty in childhood, which will lead on to real problems for the health of these communities as the children grow up. You know, if you have poor access to food and nutrition in your early formative and developing years, we know you stack up problems with increased risks of heart disease and cancer and other long-term conditions of adulthood.
Yeah, and as you say, we have talked about this, haven't we? Because there is an opportunity, and I know it always feels like you're setting it as a challenge when you say we can't raise as much as Great Ormond Street, because I always think surely the north of England, there are enough people that want to see investment in giving children access to clinical trials, because goodness me, if your child is poorly, the last thing you want to have to do is travel halfway across the country to access the best research and the best care. But I think that there is a real opportunity for the charity to raise more money so that we can invest in things like, you know, dietitian and other specialist roles within the children's hospital centered on research, and you know that the aspiration of the charity is to raise more money so that we can fund these things that we know are very important, and are going to make a big impact on tackling health inequalities going forward. So I'm just going to share a quick note from our the chair of the charity, Edward Ziff, who says thank you for the very interesting presentations, and the work that you do is amazing. So that's a note from Edward, and we haven't had any questions come in. I think it's probably because the presentations have been brilliantly informative, and everyone has hopefully got some food for thought. So thank you very much for your time this evening, for sharing the wonderful work that you're doing in the Children's Hospital, and thank you to everybody who's attended our webinar this evening. Thank you.
Thank
Thank
you.
you. Thanks for the opportunity for sharing with you.
Thanks, everybody.